Welcome back to episode 7 of the Rehab Exercise and Sports Therapy podcast, sponsored by University of Orthopedics. I am pleased today to be joined by Dan Lorenz, who has been kind enough to join us as a conference presenter in the past and a nationally renowned and published author and speaker. So, Dan, if you could just give our audience a little bit of information about your history, background, what your role is. And then I'll kind of segue into our topic for today.
Sure. Thanks, Dan, and appreciate you having me, and really grateful for the opportunity to talk about a topic I'm passionate about today. I have an undergrad degree from Grand Valley State University in 1999 with a degree in health science with emphasis in athletic training, master's in PT from Grand Valley State in 2001. I got my DPT, worked on that through early professional career through the University of St. Augustine. I did the sports physical therapy fellowship at Duke University back in 2004. Hard to believe it's been that long. Spent a couple of years in the NFL as a PT and athletic trainer with the Kansas City Chiefs. I had my own practice in the Kansas City area for about 7 years. Built it to 3 clinics, and then for the last 6 years, I've been the director of sports medicine at Lawrence Memorial Hospital and Ortho Kansas in Lawrence, Kansas, where we also started a APTA credentialed sports physical therapy residency program. And we're on our 3rd resident now. So yeah, lots of speaking, lots of writing, and pumping out some papers now, which is cool. So kind of trying to wear all the hats.
Absolutely. And it's funny, I've joked with a colleague in the past about you, especially after we had you come out and present, that I almost feel to some extent like I don't even need my PubMed updates anymore. I can just kind of follow you on social media and get all the literature updates I need. I am envious of your ability to sift through like a ton of sports medicine research. So, yeah.
Well, it's not an easy task, but I do enjoy doing it. And like I said, I do love it. You kind of know that you pick the right thing to work your craft when you still enjoy it after almost 25 years of doing it. So,
yeah. So Dan has agreed today to join us to talk about late stage. I'll say ACL, but we'll broaden it to knee, late stage rehab, because I feel like you were one of the kind of pioneers, or maybe not pioneers, but I'll say early adopters, right, or promoters of bringing, really kind of pushing strength and conditioning principles into rehab and not necessarily segregating them, right? So I wanted to kind of touch base with a lot of your thoughts about, especially late stage ACL rehab. I'm sure it'll kind of organically drift to that, but again, I want to keep it, open-ended to where we can kind of talk about late stage rehab in general. And Dan, one of the things I feel like with a lot of generic ACL protocols out there, I feel like, again, they're very specific again until you get to that 12-week mark, right? And then it just becomes return to run, plyometrics, right? And there's not a whole lot of specific information. I feel like this kind of black hole void in there. So one of the things I wanted to talk to you about was specifically adopting your strength conditioning principles and kind of talking about timeframes getting into hypertrophy stage, right? And then getting into strength stage and then segueing into power stuff. In terms of how you kind of do that from a criteria standpoint, time frame standpoint. And I also want to talk to you about BFR, but we'll get to that in a minute. If you could just kind of tell us a little bit about your preference and rationale early on in the rehab, because there's this somewhat of a debate about double leg stuff to build more max strength stuff, single leg stuff to really isolate and limit any compensatory strategies. So kind of give us a little bit of insight into your philosophy or overall framework about that, if you can.
Yeah, for sure. So I always try and use the framework of, Al Vermeil's hierarchy of athletic development. My colleague and one of my mentors, Rob Panariello, talked to me about that a long time ago. And it's interesting. I felt like I was always kind of doing it, but it just outlined it so much better. And it frankly helped me organize my treatments a lot better too. That usually starts out with obviously screening for appropriateness and obviously all the different nuances with various protocols and different graft
Sure.
considerations. Let's just take all that out for a second. You obviously have to build capacity first, and in the early post-op phases, straight leg raises and bridges are fine, but eventually you want to build them to a point where they're doing trap bar deadlifts, back squats, front squats, leg presses, and stuff like that. Well, they have to have the ability to do the work, right? So in those initial phases for me, I typically just with limb confidence and people like that, you know, if they struggle with loading it, or maybe they have some discomfort, you know, we're just assuming a straight up ACL here, no other cartilage stuff, no meniscus stuff.
No
So
other
I'm making
meniscal
some
repair,
assumptions
articular
here.
cartilage stuff.
Yeah. We're making some assumptions here, but you know, I typically start like probably most people do with, you know, using like I know conflicts of interest, nothing to disclose, but you know, total gyms or shuttles or, you know, light leg press, you know, things of that nature. I start working, you know, eccentric pretty quickly. When I say eccentric, some people get confused about, well, it doesn't mean just moving stuff slow, but being very deliberate about developing control on that involved side. We know from research going back to 2002 or 2000 in clinical biomechanics that people unconsciously unload their knee after an ACL up to a year out of surgery. And a number of other studies have followed up showing it's the same with jumping, with squatting, etc. So I want to force them early on to use that as much as possible, even if that means their good leg is providing 10 or 15% of extra help or some support just to make them feel a little more comfortable. So I would say for my first month or so, my reps are relatively high in that kind of 10 to 12 range. Usually the rest periods are very, very slow, or excuse me, very small. I'm doing pretty high volume. And when I say that, I mean, I'm usually giving people, I like to do, you know, Joe Kenn is a known power lifter and strength coach, and he talks about his tier program, where essentially you give people 3 exercises you do is a grouping that all work different things. And so for me, I'm typically doing things like a quad exercise or a, you know, quad knee dominant exercise, a hip or hamstring dominant one, and then like a supplementary one like proximal hip or calves. And that's a grouping. And I do 3 or 4 of those groupings a session. And the idea is that the athlete keeps moving. There's not a lot of rest. There's active recovery as they do the other things, but there's a lot of volume in that 45-minute to an hour-long session. And I believe that helps build the capacity to do the strength things later on down the road. I think most therapists really struggle with, again, the loading of them. You know, and some of that has to do with the patient's training background. You know, that's why when I go to speak and things, I say there's lots of ways to determine effort level in a patient. You could say like, well, I use RPE. Well, if nobody's ever worked at a 7 out of 10, how the heck do you know if they're really at a 7? So I encourage clinicians all the time. It may involve 5 or 6 changes to that leg press weight to determine like what the, not only the capacity is, but what the load is for that session. Because if you don't get that figured out right away, they might be lifting. Why would you have them lift in 3 weeks if they can lift today? Right. So it's so important to get those loads right. And a repetition ranges work. And, you know, 1RM estimates are really hard because in strength conditioning, they use 1RM estimates. Well, how do you do a 1RM estimate in somebody that has no training history and they're 4 weeks out ACL? So that's why I said things like RPE is really good. Repetition ranges is good. You know, I very much emphasize, look, if our target is 6 to 10 reps, you know, that if we get to 10, that should be it for the set. If you got 5 more in the tank, we need to go up 5 or 10 pounds. And I think using that as a template for your progressions is really the way to go. Now, of course, the limit there is what your resources are. You know, so I'm very lucky. I got squat racks and trap bars and knee extension machines and leg press and all of those things. Well, it's a real challenge. I know there's clinics out there that are 1,500, 200, 2,000 square feet and not all the toys. So that makes it hard too. So I hope that kind of gives some direction there. That's obviously a really broad question. I think for me, when I get down to it, as far as strengthening goes, I usually am always a one exercise that's double leg. I usually post the good leg. So I put the good leg up on a little bit of a step to force that weight shift. A number of studies have shown that it does increase knee extensor EMG when you do post. So I do one exercise that's double leg, and then usually 3 or 4 exercises to follow that are single leg emphasized. You can load more on 2 than you can on 1, but it forces them to load that limb on single leg. So I hope I wasn't too long-winded there, but hopefully that gives you a good 10,000-foot view of how I like to structure things.
Yeah, absolutely. And for your kind of double leg powers, I believe I've heard you joke in the past that if you could just pick one exercise, it would be trap bar deadlift, right?
Yes, I love the trap bar deadlift.
Yes, I do know that. So what's your rationale, preference, you know, goblet squatting, trap bar deadlift, back squat? Like, what's your, rationale for what makes you preferential towards that?
Well, I can always load more people with a back squat or a trap bar deadlift. And if they have a good training history, we'll do some front squats. If the anterior knee is not irritable, we'll get to those eventually. Those are
Right.
largely my three core ones, my
Yeah.
three core double leg lifts. I do those with the patients because most of them are going to a gym because I encourage them. Like I see most of my ACLs twice a week. And that third workout in the gym, they're going themselves, and 99% of them have a leg press. So I don't do a whole lot of leg pressing here. I do show them the ways to go about it. I show them, a double leg. I show them a 2 down, 1 back. And then I also show them single leg. I typically am not working single leg till much further down the road because, again, I want them to develop that body control, that
eccentric fit. Yeah.
Yeah, exactly. And that's where I think that's where the eccentric, the rehab eccentrics come in. We think about eccentrics in strength conditioning, it's always super maximal stuff. Well, obviously, we're not doing that. But like if you watch somebody, I have a video that I spoke last summer at a meeting in Scotland, and I showed two athletes side to side as an eccentric emphasized talk. And they were basically the same time point post-op. And I had them do a pistol squat to an 18-inch box. The one guy was very controlled, very deliberate, touched the box, came back up controlled. And the other one, she went down 3 or 4 inches and just fell to the box. Well, that's eccentric control from a rehab standpoint. So that's what I meant about, the 2 down, 1 back, or I have them go up concentrically quickly with single leg, but down very deliberately eccentrically. So again, you gotta develop, that control first before we do it under higher speed or higher loads, if that makes sense.
Absolutely. Yeah. Dan, one other thing I wanted to talk to you about in terms of, not late stage, but kind of early to mid stages, use of BFR, especially recently with ACL. There's been some literature coming out kind of refuting the effectiveness or integration. And I know you are a BFR proponent, and I believe you have a course out there on it. We can, give people the information on that later. But tell me your thoughts about, first off, about some of the literature out there. And then I also wanted to discuss a little bit about the history, because there's been some literature lately about whether or not sticking to the traditional 1 set of 30 followed by 3 sets of 15 is the end all be all, or if there's ways to kind of be effective and modify that and still get, some of the same benefits and carryover. So if you could just give us a little bit of your thoughts about BFR use in some of that early to mid stage knee rehab.
I think it's really important. I even did a little clinical commentary on it in IJSPT a few years back that, we have reason to be very excited about it. But, the problem is in our field, we tend to overuse things. That's why we can't have nice things, because we use it on everybody for everything, for every injury. And then obviously all these studies show that it doesn't this or doesn't do that. Well, we have to stay focused on what its intended purpose is. It is a complement. It's an adjunct to what we're already doing. It's not supposed to be a replacement. It's only a quote unquote replacement if you have somebody that is completely intolerant or incapable of handling load. And that's really what the whole crux of it is to be able to get similar benefits to high load training in situations where people are unable to tolerate normal loading methods, either due to restrictions post-op or because of their pathology. And I think if we really stay focused on that will make, I think, our utility of BFR probably see the fruits of the results more than if we're like, for example, I've seen some studies where they did sprint training with it or after it, or where they've done cross education, eccentric BFR. Now I know we're kind of exploring to see how these things work, but again, that's kind of away from the intended purpose. So like I said, for me, the whole repetition scheme thing, I think, we're still learning about some of the mechanisms and stuff. So there's more to be learned, but I mean, I think there's a lot of good research out right now that it's definitely a good benefit. I was just in a discussion online about this recently. There was a study it's actually probably the most well-done study I think I've seen as far as progressions and how they outlined how they actually did BFR. It was in Medicine, Science, Sports, and Exercise. It just got published in 2025 by Brian Norin and colleagues. I think they're at Kentucky, and they did a beautiful job outlining how they did it. And what was interesting about that study, it depends how you interpret the results. They said that it provided no additional benefit. Like people weren't any higher from using BFR, but when they compared it to the high load group, like all the metrics were the same. So it was equally as good, right? So again, it depends on how you interpret the results and why you have to read things carefully. And like I said, they did a really, really nice job. Is they used RPE as a guide because we can't use 1RM. I even put that online. I'm always confused when I see we did a 1RM, we did 1RM or a percentage of the 1RM for, body weight squats or whatever. It's like, well, how do you get a 1RM of that, in other studies that I've seen? So yeah, I mean, effort's kind of the way to go on that. So, anyway, I still think we haven't had a lot of cause to change from 75 to 90 reps per exercise. For me, though, the idea is to get as close to or at failure on that final set, where it shouldn't be an absolute number. That, oh, if you get to 15, it's over. I mean, if they got a little more in the tank, well, then you probably got to increase the weight, or you got to, you have to change the rest periods. And that's the thing. You can't be doing the same weights every time. I talk to clinicians all the time that are pulling their hair out that they see colleagues or talk to colleagues that are doing the same weight every time. It's like, well, if you're getting stronger, you should be adjusting those things too.
Right.
So, yeah. Hopefully.
30% of the 1 rep max is kind of the gold standard, right?
It is, but I mean, again, if you're doing goblet squats, which I love to do. Sorry, log me out here for a second. Nope, there we go. No worries. If you're doing goblet squats, I mean, how do you do 1 RM goblet squat?
Right.
I mean, obviously, not only can you hold the weight if it's that heavy, if you have a big athlete, but normally in those time frames, I'm taking a percentage of their body weight. I usually start at 20% of their body weight. And again, that helps you establish the repetitions. I look at their effort level. I look at how many reps they get on the last set. So there is sometimes you may have a session where you're trying to kind of figure out what that load is. No different than that first time you put somebody in a leg press. What's the best weight for them? It might involve a few different changes of the weight stack to get that perfect weight for that person at that time.
And just to confirm, you're starting it 2 weeks out just to allow incisional healing, that kind of thing.
Yeah, typically that's what I do. If you wanted to refute and say that there are people that propose doing it right away.
Right.
My reasoning, again, I'm a guy that, clinically what makes sense to me, and this is what I do. Nothing against people that do it right away. My whole thing is people are swollen, they're sore, they're in pain. There's other things I can do in those early phases to kind of calm things down first. I like incisions to close. If you're squeezing up top and
useful,
like I
right?
said, I have talked to people where they've had like some, leaking of effusion through portals,
right.
And I always say, where's the fire?
Right.
Is the Super Bowl tomorrow? Like, what's the rush? I mean, is there really a benefit to starting at 2 weeks? I haven't seen the benefit that there is. But again, like I said, for me, I wait till things, let things calm down a bit. I think there's still some trepidation from medical providers on starting that stuff early, even though there's zero evidence that there's clots from doing this. I think there's still, wait a minute, you're putting a cuff on at 80% occlusion. Never mind the fact that like you just had him in the OR for 2 hours on full occlusion,
with a tourniquet on, or
you're right. So I mean, there's some, but that's stuff we have to navigate as rehab professionals, right? So I think it's important that we acknowledge those things and those concerns for people, and then once the 2 weeks hits, I'm ready to roll, man.
Yeah, no, I feel similarly. I mean, I feel like an infected knee and graft is way more problematic than a few more days of AMI and quad atrophy. That's a lot easier to manage.
And it's not like BFR is our only tool in the box to hit AMI, man.
Right.
Like again, that's why I said. I mean, obviously you can ice the joint. There's some, you can use TENS. There's motor methods you can use. I mean, there's just endless biofeedback. I mean, there's just endless stuff you can do to get the quad going in those early phases. I'm just not, for me, like I said, not to, to belabor the point. That's always worked for me. I haven't had a sound rationale to start at that earlier, but hey, like anything else, I'm receptive to change my mind if the literature comes out and says otherwise.
So tell me, you're starting at 2 weeks. At what point do you discontinue BFR?
Yeah, it's a loaded question because
I know.
Do I got this veteran athlete that's trying to squeeze out 1 more or 2 more years and has grade 3, 4 arthritic changes in the knee? Well, I'm probably do that more often on that individual. For me, I think as they're starting to approach when they're doing the higher loads later on in towards the tail end of their rehabs, I might mix that in if they've had, let's say they had a tough workout with me and then they did they're starting back at practice, they had a hard practice and they're with me that following day. I might do BFR that day just to unload and recover a bit. But all things being equal, like I said, once that hypertrophy or that muscle girth is back sub 1 centimeter, once their strength is sub 10%, I'm not doing it, every session.
Right.
So that's kind of where I usually use as my litmus test to stop. But that said, I'll continue it on days I need recovery, days we need to unload. Like I said, I think it's an underrated recovery tool,
Sure.
and I encourage athletes, and I think there's going to be more about that coming out down the road. Like when we think about things like, the ischemic preconditioning and,
Right.
the more of the passive recovery with BFR. So again, I think that's an exciting frontier of literature that we'll probably learn more about here in the coming years.
Yeah. So you kind of set me up perfectly here. You mentioned a little bit about AMI and kind of getting that quad started early. One of the things I wanted to pick your brain about, since you already loosely alluded to it, was the difference between grafts, right? And quad tendon autografts, and what you're seeing kind of anecdotally or research wise. I mean, I think overwhelmingly the surgeons seem to love them, and I understand the proposed benefits from a surgical standpoint. Personally, I've been underwhelmed by them clinically as far as, slower return of quad function, peak torque, power, that kind of thing. But I wanted to kind of get your thoughts on when you have your quad tens, are you adjusting anything rehab wise for them and what you're seeing clinically as far as their progressions compared to some of the other graphs?
Dan, I'm going to add you to the long list of people that are experienced clinicians, like really experienced, that are scratching our heads looking around like, why is everybody so excited about this graft? Like,
Right. I mean, from a surgical standpoint, I
I'm one of them.
understand it. But
So
once I see what the results are, clinically, I'm like, yeah, you're actually probably prolonging this person's rehab and recovery by doing it this way. So,
I understand from surgeons that it's like the easiest graft to take. It's robust. They don't get that anterior knee pain that bone patellar tendon bones do. But I'll tell you what, that's our fault as rehab clinicians. I say it all the time.
yeah,
I think the anterior knee pain from bone patellar tendon bone grafts is our fault because we push them too quickly, concentrically. I don't have that, and it's not boasting. I just don't have that problem, because I'm such a more eccentric, emphasized person in those early phases that I just don't have an angry knee. You know, if you look at the re-tear rates, I mean, depending on what paper you read, what meta-analysis you read and all that, I mean, the re-tear rates and all that stuff are kind of roughly in the same window. I can't say there's certainly, again, it just depends on which study. So the bottom line is I'm underwhelmed with quad grafts. I agree that they take forever to get better. I don't believe the timeline's any better. No graft is perfect. I don't like a blanket graft choice for everybody that I see. I'm sorry. It's a different graft choice for me if I have a offensive tackle versus maybe a young high school female,
Right.
So I think all those things are a little bit different. I've said several times that I would always go back to the bone patellar tendon bone. I still think it's the standard in my estimation for right now, but I've seen great results with hamstring tendons too. It depends on, you're picking your poison, right? Is it 11 months or 10 months for the quad to get back, or is it 11 or 10 months or whatever for the hamstrings to get back? So there's there's arguments to be made for all of them.
Yeah.
But yeah, I'll add you to the list of people that are kind of like, what? I don't get it with the quad tendons, but whatever.
So are you finding you need to modify anything for them?
Yeah, you're right. I'm sorry. I forgot that piece.
No, that's fine.
So
No worries. Yeah.
I think the only thing I do differently for them is they start, when I start stim in the early phases, they're laying supine with because it gets rectus too. So 2 joint muscles. So you want to, so like my knee extension machine is the seat's way back. So they get more, where there's less hip flexion.
Got it.
That's the one modification. And I don't know of another one that I do that much differently other than that piece for a quad tendon graft.
Sure. Okay. All right. So we had mentioned a little bit before about kind of the black hole void with a lot of rehab things. That return to run phase, I feel like, is always a little sketchy, and there's so much variability out there in the literature about what the criteria are to be able to return to run. So I wanted to just kind of get your thoughts. What are your benchmarks, or what are criteria you need to meet for somebody to be able to return to run? And then also, what do you do kind of as the preparation or the kind of pre-return to run phase with them before you initiate it?
Cool. Okay. So I've always referenced the article from BJSM a few years back. I think Sierra Berge and some colleagues put it out. I hadn't had a reason really to go away from that. Frankly, it's worked well. In that, they obviously in that article, the summary they proposed, just full active range, no effusion, 70% hamstring and quad strength compared to the uninvolved side.
Sure.
And then a step down test. We typically do a 10-inch lateral step down test for 30 seconds. I like to see that one again, sub 10% difference for that at that moment. So those are the ones that we typically use to allow them to run. Now, whether or not you have isokinetic machine or you have a high handle dynamometer, there's some good correlations with those. So I think, if you don't have all the toys like I do, I think you should feel good about the fact that at least you have a dynamometer. There's crane scales. There's other options out there these days that you can use to get it.
Deck for a couple $100.
Don't use the dang manual muscle test though. Please don't do that.
Yeah.
So that's what I use for running. As far as the things leading up to it, usually I do a lot of retro treadmill walking uphill.
Okay.
I think that's a really nice precursor. Typically, I have people go 20 seconds on, 40 seconds off. They're starting that usually, if they're appropriate for it, about 2 to 3 weeks before I'm thinking I'll start them to run. It's a great home exercise adjunct as well, because they can find a treadmill. I usually am about again, as they get comfortable, I'm at 1.8 to 2.5-ish speed, about its full percent grade. That's a really gets those quads fired up, and it's a good, like I said, a good precursor to running. If they're having any limb confidence issues, I'll of course do some impact stuff on a shuttle or a total gym first, maybe some suspension bands to get them to, if they need it. But I just don't find most don't, but that's how I'd regress if I had people that were struggling with that. So like I said, that's always been my template. I haven't had a reason to go back from it, and even Megan, I think Megan Graham did a study on this where they looked at, and her study showed most likely to succeed, should be okay, and likely to fail.
Yeah.
And it was right around that 70%. It was in Newton meters. I don't remember the exact numbers, but her paper supported that too. So, and she's done a lot of nice work on the quad. So I don't know if you're going to watch Megan.
She just presented at CSM last year all about quad.
Yeah, she's really sharp and done some great work. So Megan, high five to you for the work you've put out with that.
So one of the other kind of philosophical debates out there with return to run that I wanted to kind of pick your brain about, and I think actually you had just posted about this the other day about running kind of being the most basic plyometric exercise there is. I know there's a camp of people that feel like because running is single leg plyometric, we should do some course of double leg plyo stuff prior to initiating running. And I wanted to kind of get your philosophical thoughts on, are you doing pogos and then progressing into running? Are you doing box jumps? Like, how do you kind of transition or segue into that?
Yeah, it's a good question. I mean, it really, and this is where therapists, I think we're just not very good at this, like the semantics piece of this. Running is bounding. I mean, that's what it is. Like if you do a scissors, like you're in a split position and you jump in place and switch in midair and land. I mean, largely that's what running is, right?
So that reciprocal,
plyometric is, measurable increase, right? That's what plyometric breaks down to. I'm not doing plyometrics in early phases when there's a 30% quad deficit, so we're doing, jump, land, retraining. But also too, we shouldn't speak in absolutes. Just because I say start running, it doesn't mean go run 5 miles. I do walk, jog intervals. I have 30 yards of turf in my facility. If I have them jog from one end to the other, is that running? You know what I mean? So we're just not good at describing this stuff. So off my soapbox here, but to answer your question, I typically start, land-based jumps. I'll start with some snap downs where they start tall and get low and stick the landing. Like I want to see before they're doing repetitive jumps, I like to see that that scissors, going back to that, they're in a split position, they jump and they switch in midair. I want to see them stick the landing with an isometric hold, get good at that before they're doing it, consecutively. But all that being said, jumps in place first. I typically jump to a box first. When you bring the landing surface to them, the instantaneous second before you come back down, you're weightless. I bring the box up, your impact forces are lower. So jumping, I show proficiency there first on 2 limbs, then jumping on land in place. Broad jumps have a little more ground reaction forces than jumps in place do. But I don't do jumps from box to the floor until they're, sub 15% differences when we start that towards the later phases. So that's on my progression there. Now, as far as volume and things goes, I had this discussion the other day with somebody else. The NSCA, National Conditioning Association on Healthy Athletes, uses 80 to 120 foot contacts a session as a beginner range. And now, of course, it's the range because if you have trained athletes and stuff, it's different. Their training history and capacity is going to be different. But so what I've always used is taking half of that as my starting point. So my first session is usually 40 to 60 foot contacts. And then what that does is that by going up a little bit at a time and starting there, you get an idea of what the knee's capacity is. Right. I find a lot of the struggle with most clinicians at this phase is that the athlete comes back swollen and they're scratching their head. Well, what did it? But if you really went back and looked at your volume and what you did, and hey, they could have done something they shouldn't have outside of the clinic. Let's be clear about that. But I mean, most of the time, I think we're not accounting for volume well enough. So I start 40 to 60 foot contacts, somewhere in there. I'm increasing a total of another 30% or so a week. And then, going up from there and letting our knee, kind of tell us how they're responding to that. So use swelling as an indicator, knee soreness as an indicator, how long the soreness sticks around. Right. So those are my things that I look at as far as progressing and starting from there, and then how to move forward with that.
Okay. All right. So on that note, as far as progressing from running, right? If we're looking at more sport specific things as far as training, change of direction, if you can give me a little bit of your framework for that. And I don't know if you've ever read Damian Harper's stuff, but he's got some great stuff out there.
His course is excellent, by the way. Yeah, it's really good. He does a really nice job.
Yeah. So tell us a little bit about how and when you start to integrate that, and any pearls you have for, the ideal progression, or especially what you're looking and assessing before kind of progressing.
This is where I talk about a lot, Dan, that rehab performance starts pretty early in rehab. What I mean by that is, like, in order to cut or change direction, you got to shift weight to one limb, right? Well, doing something like a lateral lunge, are you willing to get your hip over your knee, like where you actually shift weight all the way over, or are you kind of staying away from that knee? So that's why I said performance starts much earlier than we think. So that's my preface on the rest of this answer. Otherwise, once they have that, I'm able to start jogging. I mean, we're doing some lower intensity 45-degree cuts. We're doing some your run forward and backward running. We're doing wide turn figure of eights. Getting them to lean into that. Let's assume the left leg, it's a left ACL. Getting them to lean into the left as they turn left, because they tend to skip in those early phases. Sure. So for me, it's a lot of reps. It's lower intensity, short rest periods to build the capacity. But I'm not hitting like high intensity decelerations, like full speed, sharp, like hard stopping with a short stopping distance
window. Yeah, right.
Until there's sub 10% difference. So like the drop vertical jumps, the depth jumps from boxes to floor and whatever, that's not until they're sub 10% difference, because the knee just doesn't have the capacity to handle that yet. So and we know from, you mentioned Damian Harper, Tom Dos Santos has done some really great work on look up his stuff as well. Change of direction. He talks a lot about that penultimate foot contact. It's the contact before the cut. So that, because a lot of times we're putting too much load on the cutting limb and unloading let's assume the involved side is the involved side is not the cut leg.
Right.
Well, we're unloading that one and putting more on the cut leg, which may eventually lead to that re-tear of that other knee. You know what I'm saying? Right. So there's some really good literature out there from Damian Harper, Tom Dos Santos. I mean, those are just a couple guys off the top of my head, but highly encourage you to check out their work.
Take a peek at that. Yeah.
Yeah.
Okay. So good segue again into neurocognitives. I know when we had you out to speak, we were fortunate enough to also have Dustin Grooms join us, and that was before he really exploded to
Yeah.
become, you
It
know,
was kind of new at the time. It was the new
he-
shiny toy. Yeah.
exactly, right.
Yeah.
But I wanted to kind of get your thoughts. There were a couple IGSPT webinars about this recently. But I wanted to kind of get your thoughts about, first off, when and how you begin neurocognitive training, and also again maybe some of the toys or tools that you're using for
Yeah.
people that are again running smaller clinics, easier ways that you can do it without maybe shelling out 100 AAA's pods or that kind of thing, like how you go about
Yeah.
it. So
Yeah. Yeah. No. So I know people are proposing to use it really early, like, early on when Dustin was talking about this, like he had the Google Cardboard and the
yeah,
VR apps and, or
right,
take people out to their soccer field. They can do Google Camera and those kind of things. And it puts them in the context, and they do quad sets while they're doing that. It just different. You don't want them staring at their knee, right, while they're doing quad sets.
right,
So
sure.
there's people that, people are doing times tables and all these little brain games. And that's
Counting
fine.
backwards by sevens. Yeah. Oh yeah.
Yeah.
Yeah. Yeah.
I haven't done a lot of that acutely yet. And
Okay.
maybe that's, because I'm a grizzled old vet and my ways have been working,
Fair enough.
so,
Yeah. Right.
but doesn't mean I won't check, because I've added the neurocog for later.
Yeah.
Now, I talked to Holly Silvers came, and she's obviously brilliant, done so much good work in our field. She came last summer and spoke at our sports med symposium that I'm the chairman for here. And she's using it a lot. And I had asked her, anytime I do any of this neurocog stuff, inevitably the speed of performance decreases.
Right.
They're so concerned about doing the times tables, or which color to go or no go on the Stroop test, or the strobe glasses, or whatever you're using. I mean, all those tools are fine, but you really do have to do both
Yes.
in those phases. Like, so for me, I'll give you an example. So I have a gal that's a ACL. She's about 4 months or so, and once she demonstrated proficiency in broad jumping, vertical jumping, we did some bounding without any kind of neurocog stuff. Well, then I would add those wrinkles in for that session. But then as I progressed her jump, she would do the progressive jumps without that, right? So for me, we've done, I call them pursuit drills. I'll set up cones and I'll throw balls, and it's random. So there's a change of direction and reactive
Sure.
piece.
Yeah.
So we
And
do
more
those with
contextual and sport specific that
right.
way
We do
too,
those
right? So yeah.
with glasses and without. Inevitably, they're always faster without the strobe glasses, right? So you really do have to do both.
Yeah.
And I would encourage you to do both. I have another gal. She is probably within a month of being fully cleared. She's a high level elite volleyball player. We're doing the reactive jumps from box to floor and up to a box and those kind of things. She demonstrated proficiency without the glasses. We put the strobe glasses on, and holy moly, did that change things. So we've been really kind of working on that in addition to what she's doing. She's already back to practice and doing all that stuff, but those are things I can do with her here. So again, long answer, simple question. We need to do it. I still like Dustin's way he screened for it way back in 2017 when we spoke together at your place.
Yeah.
Having people jump in place with their eyes open, and
Yeah.
then have them
And then do
close
it
their
eyes
eyes and
closed.
jump in
Yeah.
place. And if they're all over the map, they are definitely an athlete that's visually dominant, and we have to desensitize them through those other visual things, or like I said, the brain act, or the cognitive piece.
Yeah. I mean, it's funny when we did that demo, and I've not had a major traumatic knee injury, but even doing it myself with my eyes closed, I was like, oh my God, I am terrible at this. And I'm worried about tearing my own ACL doing it.
Yeah.
So
Yeah.
much less somebody that's already compromised. So
Right. And the bottom line is, Dan, I say this all the time, we can do all this stuff all you want, but it's just never going to actually exactly mimic what the best thing we could do is to get them back in the context of what they're doing. I let people back, once their intensity at practices matches what their values are here. So if my athlete is at 80% of strength on hamstrings and quads, well, then you're not, you're at 30, 75% or so effort at practice and some of that volume, right? Like you're not going the full practice, but again, all the cognitive stuff from coaches, from hearing people yell on the court, teammates saying stuff, fans, parents, like we're not going to be able to produce that no matter what, no matter how much we try.
right.
We just can't mimic it until they get back in this context of their sport and slowly increasing that from there.
Yeah. And I don't know about you, one of the dilemmas I always have is I treat a decent number of high school athletes with a limited training history. So I feel like sometimes I spend so much time in the session to chasing the strength to meet the benchmarks that sometimes I do some of the neurocognitive stuff, but never the volume that I want to. Again, I go to some of these courses where they're doing it very in depth, and I'm like, I only have an hour with this person, I
Yeah,
need to, yeah. So
yeah, and I know it's fun to use the new toys and athletes like them and those kind of things, but I've even talked to Dustin about this. Meredith Chapu is another one I've talked to
yeah,
about this. Like, we can't take our eye off the ball. They look at nobody says in any of these studies that they didn't do good on the Stroop test and they didn't go back to sport. Every issue is their quad strength stinks.
yeah,
Right. So we have to focus. Don't take our eye off the basics. Be an expert at the basics. Load them up. Get that quad and hamstring strength where it's got to be to get them in those windows so they can get back safely. Yes, if you want to add that stuff in and you have time, that's great. But who cares if they can do times tables, while you're running passing routes, but their quad strength is hovering still at 85% what it was 3 weeks ago. You know what I mean?
yeah,
So
right.
it's so important that, stay focused on the impairments that are limiting them from getting back to sport.
Right. And that you're right. I mean, Meredith was just on a journal club through the sports. I still call it the sports section. I know it's not the sports section anymore. It's AASPT, right? But she was,
Yeah. Old dog, new
um,
tricks, man. It's hard to
but
do.
yeah, her still like kind of underlying message was just do the basic things well. So yeah,
Yeah. Yeah.
right. So,
And I don't think we do
um,
that well enough, obviously, with the loading of
right.
people. If we
No,
were, we wouldn't see 30-40% quad deficits at return to sport.
or the huge retail rate to some
Yes,
extent, right?
exactly.
Yeah.
That's what I
So,
said.
right.
We're not even doing
Yeah.
the basics well enough,
Yeah.
So it's so important to learn how to load people. It's just critical.
So on that note, let's say we have somebody that is loading well, from a strength standpoint. Tell me a little bit about because RFD, I feel like is kind of the holy grail, right? As
Yeah.
far as like getting that back, it's the last thing to come back, right? And some people we know it doesn't come back well or completely. So tell me a little bit about first off how and when you begin to train it, and then what you're doing to assess it, because I know, again, depending on who you talk to, right, if you're using a Tyndek or a dynamometer and there's a little play in the system, that measure is very sensitive, right, to how
Yeah.
you physically set them up to assess it. So tell us some of your tricks or toys and
Yeah,
you know
and I've talked to researchers about this, and I know there's been some changes to like the time to peak torque. They've added this on a lot of the isokinetic devices and stuff, and we tried to look at it here, but the problem, it's just so messy.
yeah,
Everybody that I talk to and read, and admittedly, I'm not the smartest guy when it comes to a lot of this, a lot of the measurement of this, but I mean, you got to take up all of the slack. Like, there can't
right,
be any padding that you kick into. You got to take up that. You can't let them wind up. Like, you've got to take up their soft, like they can't pull back in flexion and then kick out quickly.
right,
Like,
right,
all of those variables you have to correct for. So it's really hard to do in our field on a day-to-day basis. Is it clinically relevant for most therapists to talk about that? Not really, because how are we measuring it, right? I mean, yeah, if you're in the weight room and stuff and you have, tendo units or whatever, you can measure,
sure. Something to measure bar
force
speed
velocity
or yeah,
profiles. Like, yeah, that's great
sure.
if you have the ability. But again, 99% of therapists don't have that in the clinic. So I really try and focus when I speak or talk or answer, things like this,
Yeah,
like what can you control? And I think one of the things you can control is something as simple as single leg box jumps up and down, get as many done in 10 seconds as you can, right? You can
sure.
work on something as simple as, one of the things I always like to do is what I call a bench to box, where they're sitting on a weight bench, there's no counter movement, and they got to jump single leg up to another box as quickly as possible.
Yep.
I often show like a split screen of two knees, right? Like a right and a left and the operated side. You just see them. It's like they got a 10-year-old on their back. They can't get going.
Yeah.
Yes, there's probably a strength issue there, but I mean, if there is a deficit, but obviously it's doing it quickly. So doing things as fast as you can. You've got to get that. You got to tell people, get that violent arm swing when you're doing stuff. Uh, we have to make them do stuff quickly. And there's been studies from the 80s and 90s that even thinking about doing something fast, even if you don't feel like you did it
Sure.
fast, you'll be doing it faster than probably when you think you are. So
Yeah.
that's why I said, I think just telling people, push hard, push fast, as quickly as you can, be as explosive as possible. Violent arm swing. A lot of it's cueing in those phases. That's what you can do clinically to help make that piece.
Yeah, I feel like that's where the cueing piece is huge, right? Telling,
Mm-hmm.
Push the floor away, push as fast as you can, those kind of things.
Yeah. Ground is hot, reach for the ceiling, like those kinds of cues, like, hot, 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 saying that stuff when they're doing these things and timing them. Like I said, I mean, anytime you add power, or excuse me, anytime you add time to a test, you make it essentially a power test, right?
Right.
So if like the other day I had another gal, she did 12-inch hurdle hops, single leg, while I was timing right and left side, to look at the differences in side to side and trying to better her time each rep, right? That's getting a little bit into obviously the rate of force development, spending less time on the ground, getting off it quickly, right? We know that the greatest athletes do the two things better than anybody else. They put more force on the ground. They spend the least amount of time on the ground as possible. So anything we can do to work on those two things is good stuff.
Yeah. And I also feel like from a psychological standpoint, I mean, the whole reason they're going through the surgeries to get back to competitive sport or get back to competitive level function. When you start introducing that competitive element to it, where you're timing them and tracking this stuff, I feel like you do get more buy-in and effort from them as well. So
for sure, 100%.
Yeah. So this has been great, Dan. I know I don't want to cut into too much of your day here and time, but I wanted to kind of pick your brain about a couple things. For our audience is pretty varied. So for any students listening that are doing kind of a late stage knee rehab or just entering into that, what would be your pearls or advice to them?
Well, let's just assume that they're still at a strength deficit. Make sure your loads are right.
Yeah.
No, really, make sure your loads are right.
Yeah.
And I say that all the time. Whether you're using RPE, whether you're using repetition ranges, it's probably not going to be great to use a 1RM. You're going to have to probably use RPE or repetition ranges. Make sure it's right. If they do a set of trap bar deadlift and they finish the set and they're just rolling into a conversation with you without any kind of a catching their breath or without that PT face, where you're like effort face, like if there's no effort face, if there's no heart rate change, it's not heavy enough. So their knee's not going to explode if you had 10 more pounds of the trap bar. Okay. Like if we have to push them. So don't be afraid to add a little more weight, control the volume. If you look at literature from 20 years ago, the greatest effect sizes in strength is 8 to 10 sets per muscle group and 3 to 4 sets per exercise per session. So what does that mean? 4 sets of trap bar deadlift, 3 sets of a loaded barbell step up, and maybe 3 sets of a seated knee extension. There's your 10 sets. But the loads have got to be right. And you have to emphasize that to your patients too. Teach them what the right load is when they're working out on their own, especially late stage where you're down to maybe 1 session a week, 1 every other week. That's a lot of time they're not with you. You have to teach them what the load being right looks like. Okay. So it's so important to get those loads right and, to make sure they know what the effort level really is.
Excellent. That is excellent advice. And that is, like you said, I mean, especially for the person with a limited training history that's not accustomed to what it should feel like and that discomfort, I feel like that's one of the hardest pieces to get them acclimated to the level of effort and output they should be, at. So
I'll give you a quick example. So I have a kid right now. He's far out now. He's about 6 months post ACL. Never played a sport in his life, but he was playing ultimate frisbee in college student here at KU. Never, like I said, never lifted a weight in his life. And, the first day we did trap bar deadlift, I was teaching him how to do the movement, you know, and when, I said, oh, look, I want you to about a 7 out of 10 on the effort here. So we did it. And he's like, that's a 7. I'm like, you sure? And we did it a next set. And he's like, yeah, it's probably a 7. We went up weights 5 times before we really got to, okay, like I could see the effort was up. Like when I said gets, 8 reps, he really was cashed out. Like 8th rep was really hard.
Yeah.
That's where we started. And think about students, if I would have stayed with the 5 weights below, how much time and sessions I would have wasted getting up to what he can do today.
Absolutely.
Yeah.
Yeah. Tell us also, Dan, tell us a little bit about something for 2025 here. Tell us what you're researching or something you're trying to get better at or learning about here personally.
Man, I'm still trying to get better at stuff, especially the technological piece. I'm kind of an old dog, man. Like we didn't have all these toys back then, the force plate stuff, trying to
Force, yeah,
understand it, what all the things mean. I got some young therapists that just know all this stuff so well. And it's like, holy moly. So I'm trying to understand that better so I can interpret results better.
yeah.
But that being said, I'm still a voracious reader, trying to keep up, but changing practice on things if things come up, so I can't say there's necessarily something new. I'm always keeping up on new either devices or like products that people are looking into. Like I've heard peptide injections like so
Oh,
much the
yeah,
last month. So
yeah.
just again digging into that a little bit and talking to people that are in the know. I think that's kind of for me where I'm at on things. I'm still I learn from a lot of people that are in the trenches still. So I talk to a lot of people that are in the industry or people I know in pro and college sports, like what they're doing for this or what they're doing for that. It keeps me going. So I'd say those are the things for me. We are doing a research project here. I'm excited to see the results eventually. We're doing isometric mid-thigh pull in the
Oh,
early
yeah.
stages after an ACL. I've had a few my athletes go through it. Their numbers are really great. So maybe there's something there because we don't have anything on acute ACLs with that. So I tell my main research guy here, Danny Larson. Many of you may have heard him speak
Oh, yeah,
before. He's
yeah,
acting the
absolutely.
ASVT. That might win an award if we can really make those results look good. So if those really show up, because nothing out there on it. It's a strength conditioning principle that you can use in rehab.
Right.
So
And fairly early on because it's a
yeah,
bilateral task, right? Yeah.
yeah.
So,
I
yeah,
use the heck out of those anyway. So like I
yeah.
said, it's a great exercise early on. So that's, I guess, for me for 2025. Continue to
All
sharpen
right.
the axe.
Awesome. That's great. And then last question for you, Dan, before I let you go here. Tell us something that we won't find on the website or the bio about you. Tell us a little interesting personal anecdote,
Oh boy. Let's see.
hobbies,
My
interests.
I love to make, my wife and I make wine. So
Okay.
we like wine a lot. I also am a cigar nut. So I've even taken some courses on different cigar regions, how they're made, how to buy a cigar, I guess. So that's, I suppose, what I do in my free time. But I'm also just a voracious reader. I'm a
Yes.
busy dad coaching kids and doing stuff at our church and things like that.
Yeah.
So that's how I spend my time. But if those are, I'm big into smoking. Like, you're in Kansas City, man. You gotta
You
smoke
gotta do
stuff here.
right.
You know. So
Yes.
yeah, always tinkering with that endlessly, because you could do something different every day of the year if you wanted to. So
Right.
that's where I'm at with the fun facts.
So speaking of smoking meats and barbecue, I have to tell this little anecdote. After we had Dan out at our conference, you told us a little bit about your barbecue history and kind of improving your barbecue skills. And you sent a picture that was labeled food porn to the work email.
Yeah. Oh my gosh.
And
Yeah.
I was
Well,
so terrified. I'm like, oh my God, when the IT guys are going to show up
yeah,
here
yeah, yeah,
taking
yeah.
my. It was
Well, there was a
great.
big
And
picture of barbecue
honestly,
right there, so there's
yes.
no,
And it
yeah.
looked fantastic. But that's my lasting memory of one of the first
Yeah, sorry,
interactions with
man.
you was, yeah.
It's just my personality. It was one of those ones
No,
where
all
wasn't.
good. Yeah,
Yeah,
right.
yeah. Next,
Unfortunately, I'm still employed here.
yeah.
They didn't take my stuff away. So
Well, I
yeah.
was hoping the food prior to that would have been
Yeah,
okay.
yeah, right.
Yeah, yeah. Well, I think it's
All right,
because so much of
awesome.
my talk had so many pictures of barbecue in there. So yeah.
Yeah. All right. Well,
Well,
thanks again for your time,
yeah,
man. This has been
man.
awesome. And I said I don't want to cut it too much in your day, but this has been very insightful. And I love, because you're so knowledgeable in this area, I always love just taking the opportunity to pick your brain and get your thoughts about how you're doing this, especially since, like you said, you do it at such a high level and it's so kind of scientifically grounded and the progressions and everything so rational. I always love kind of anytime I can sit and chop things up with you a little bit. So it's been great.
Well, very gracious of you to say thank you. Had a lot of people before me that taught me a lot of things. So that's always why I'm just kind of passing it on as well. I know you could have invited a lot of other people to talk about this. So I'm grateful you asked me to come, and always good to see you and visit with you, of course, as well.
Yeah, always. All right. Thanks again, Dan. Good luck with your day here. And to our listeners, we'll be sure and get the show notes together for you for any of Dan's products and to reach out to him with any other questions you have coming off the podcast.
Thanks, Dan. We'll see you.
Thanks, guys.